Radiation therapy is often extremely well tolerated in colorectal. Technology has really changed things, but location of the tumor can affect side effects, such as radiation dermatitis. If a patient has a low-lying tumor, so if it's less than 6 centimeters from the anal verge, patient is likely to have some skin reaction. It's good to be proactive if that's the case.
You're listening to the ONS Podcast, where ONS Voices talk cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Hello, and welcome to the ONS Podcast. I'm your host, Jamie Weimer, Manager of Oncology Nursing Practice at ONS. And today we're talking with Lorraine Drapek, nurse practitioner in the Department of Radiation Oncology at Massachusetts General Hospital in Boston, about radiation side effects in colorectal cancer. This episode provides free NCPD contact hours. To receive credit, please review the episode notes for any guest disclosures before listening. Following the episode, complete the evaluation we've linked in the episode notes. Welcome, and thanks so much for joining us today, Lorraine.
Oh, thank you so much for this opportunity, Jamie.
So to start, can you give us just a brief overview of how radiation therapy is used in the treatment of colorectal cancer?
So radiation is used as part of usually neoadjuvant treatment prior to surgical resection. It's usually the second step. Neoadjuvant chemotherapy is usually given first over a period of about 4 months. It's often a 5-FU based, such as a FOLFOX, followed by radiation therapy. Radiation therapy is given over a period of 5.5 weeks, 28 fractions, 5 days a week, and it's to the pelvic area. There are some situations where people may have to go to surgery much more quickly, or they don't have a great performance status, so they will give 5 treatments and higher doses to those special populations. In recent years, there has been more non-surgical management of rectal cancer, especially in the low-lying, what we call the low-lying population. This is the population of patients who would likely end up with a permanent colostomy because their cancer is so low in terms of being close to or involving the anal verge. There's now a regimen where these patients can get their chemotherapy followed by their chemoradiation and then be monitored on close surveillance without surgery. It's a population that has to be not too advanced with their cancer, with a good performance status. They will have frequent colonoscopies, frequent MRIs, as well as CAT scans.
Talk a little bit more about how radiation is used in combination with some other treatment modalities.
Radiation for rectal cancer is usually used with a 5-FU based chemotherapy, and it's often oral chemotherapy, an oral 5-FU derivative called capecitabine. Patients take this medication daily on radiation days only. And what chemotherapy does, certain chemotherapy, such as the 5-FU based, it enhances the radiation to be able to work more powerfully. They work synergistically together to make the radiation more effective. It's not always oral chemotherapy, depending on circumstances. Some patients need to have something like an IV-based chemo, like a weekly 5-FU, or some even continue on every other week FOLFOX, depending on what the stage of their cancer is and what their response has been to previous chemotherapy.
And so as we're working with our patients and they're leading up and preparing for their first treatment cycle before radiation therapy actually begins, what are the assessments that we as oncology nurses should be performing? And are there any specific tools that you would recommend for those types of assessments?
I definitely would recommend the fatigue activity scale. These patients are going through 5.5 weeks of treatment. It usually is extremely well tolerated, but there's often a younger population now of these patients, and they're working. They're fitting in treatment with work. So definitely a fatigue and what their activity is like. Also, would baseline pain assessment, have they been having any pain during their chemotherapy, or any pain now that involves their tumor area or the pelvis. And then also, I guess I would recommend a stool chart in terms of what are their current bowel movements like. Patients with Crohn's and ulcerative colitis are at higher risk for developing colorectal cancers. And sometimes they may have a patient, nurses may be caring for a patient that has a history of Crohn's. So there already is a challenge of Crohn's medications and frequent bowel movements. Another assessment would be a nutrition assessment. What is their diet like? Has there been weight loss? If so, how much? What have they been able to tolerate during chemotherapy? Another assessment would be to assess what effects have they had from their chemotherapy that they're bringing with them. Folfox-based treatment is commonly used, and the platinum therapy, oxaliplatin, often causes peripheral neuropathy. What is the patient having? What are those symptoms like? Are they having peripheral neuropathy? If they are, that is likely not going to get better or improve during their whole course of radiation. In fact, sometimes when oxaliplatin therapy stops, the peripheral neuropathy can get worse as patients are going through other treatments. So that would be an assessment to have, would be their peripheral neuropathy. And again, we talked about their overall performance assessment. What is daily living like? What are their activities of daily living?
I think that's so important of just establishing some of these baseline measures for our patients so that as their treatment proceeds and we know some of these toxicities could potentially worsen because of the radiation or other therapies that they're on, it's important to know where they started. And so I appreciate you calling out some of those. Now, we've touched about on side effects a little bit, but let's talk a little bit more in depth. What are the most common acute side effects that patients might experience from the radiation for colorectal cancer?
Radiation therapy is often extremely well tolerated in colorectal. Technology has really changed things, but location of the tumor can affect side effects, such as radiation dermatitis. If a patient has a low-lying tumor, and by a low-lying tumor, I mean, if you look on the MRI, they tell you exactly where the tumor is. So if it's less than 6 centimeters from the anal verge, patient is likely to have some skin reaction. It's good to be proactive if that's the case, and then proactive in minimizing radiation dermatitis effects, such as keeping the area clean, good washing of the area, and prophylactically starting them on or having someone start them on steroid creams a couple of times a day to minimize that radiation dermatitis effect in the long run. That's one key area. With higher tumors, they may have more of radiation proctitis symptoms, so having some pain on the inside, where provider may need to order something like a hydrocortisone suppository or a proctafone or something like that. Others, again, an important reason to know their baseline bowel movements and nutrition is sometimes patients can get some loose stool, and it's important to do early teaching that it's helpful to have antidiarrheal medication in the house and available for them in case they need it. Dietary options, we let patients eat what they want to eat if they're eating okay. And so that's why a nutrition assessment is so important. It's so important in that if you have patients that are eating a well-balanced diet, pretty much I would encourage them to continue with that. If they're not eating a well-balanced diet, or if they're not getting the caloric content that they need, and you have access to clinical nutrition, a nutrition consult is always very helpful. Other side effects that can happen, but are unusual, are nausea. Nausea can happen from the capecitabine, and to have anti-nausea medications prescribed and also counsel patients on how to take them. They also can develop increased urination. Both men and women may be up at night. For women, if they do develop increased urination, they really do need to have a urinary tract infection ruled out in that case. Other than that, radiation is overall well tolerated. It's possible to see some fatigue. It can be at the end of that treatment, but a lot of that is often related to, number one, lifestyle. If they're working a lot, caring for a family, what are the other parts of their lives? and how are they tolerating the treatment overall in terms of self-care measures.
I think that's so important, as you mentioned, the stage of life that a patient is in and the context that they are getting their treatment within is really important. And it's part of that initial assessment, that baseline assessment, but also using that information to watch for and educate about certain side effects that could become more prominent or have a greater impact for patients, depending on what their circumstances are. If they're working, do they have young children at home? The way that we think about side effects really needs to be tailored to the patients and the families that we are helping to care for. So I really appreciate that perspective that you bring. What are some of the preventative or even management strategies, both pharmacologic and non-pharmacologic, that we can employ to help our patients deal with some of these acute side effects?
So for the fatigue, mild exercise from the beginning, even if patients don't exercise at all, even to recommend to them, go out and take a walk for 10 minutes, 2 or 3 times a day, helps with sleep, helps with appetite, right? It helps us in a lot of different ways, helps mood. So that would be helpful in helping minimize fatigue. In terms of bowel movements, there's not a whole lot you can do about that other than if diarrhea starts, to be proactive and take antidiarrheal medication. And usually the rule of thumb I use is that if patients normally have 1 bowel movement a day and they get to 3, it's time to take diarrhea medication. Also, along with that is to prevent dehydration, is to drink adequate fluids. We always recommend patients drink at least 48 ounces of fluids, the majority of that being water, to stay well hydrated, both from a diarrhea perspective, but also radiation tends to boost the metabolism a little bit. That's why we often don't see patients gain weight and see some weight loss during radiation. But patients can also be a little drier. So fluids and staying well hydrated is key. Skincare regimen. If a patient is given a skincare regimen, to reinforce the importance of following that. You'll run into some patients who believe that because they're not having any symptoms, maybe they don't have to do the skincare. And we really want to be able to prevent and minimize those symptoms. A good night's sleep is also very important in helping them get through the treatment and being able to do their self-care as well. Last but not least, I'd like to talk a little bit about women getting radiation, pelvic radiation for colorectal cancers right now. And this is also a measure for anal cancer. Vaginal dilators during radiation therapy are now used. Nurses may be called upon to do some teaching from the beginning, where patients will have to fit themselves with the dilator that will be in place daily as they get treated. They will put the dilator in. When they're in the room, they'll be given some privacy, and that will be in place. And what that does is it minimizes the exposure to the vagina. It lifts the vagina away, the anterior vagina, away from the tumor. That helps minimize vaginal stenosis. Patients will still get some vaginal dryness, but it is key for their sexual health and vaginal health going forward to be able to do this for patients. I would urge nurses, and your center is not doing this, it is in the NCCN guidelines, and to discuss with your team the possibility of implementing vaginal dilators in place during treatment.
Such an important side effect that can be managed. I really appreciate you calling that out specifically because, as you mentioned, it may not be common practice for all sites. And that is something that we need to be sure that we're reviewing guidelines and making sure that we're providing guideline-aligned treatment recommendations. And so a great topic to bring out and call out specifically. So thank you for that. Now, we've talked a lot about acute side effects. Let's transition to talking more about some of the more chronic or late side effects. What are the typical side effects that we would see later on after the conclusion of therapy for somebody who's received radiation for colorectal cancer?
So late effects are after 2 months of treatment. And one that I just mentioned, vaginal dryness and vaginal stenosis are definitely 2 side effects that are prominent that women experience. There can be some permanent bowel changes as well. Usually that is in line with surgery. And they have a new normal on having bowel movements and changes that was very different than what they had previously. Men also could experience some erectile dysfunction especially if they had some before a treatment, it could get a little bit worse as well. But those are the most common long-term effects that patients find pretty distressing. The radiation dermatitis, if we can stay ahead of that, patients don't have a lot of skin issues at the end where they will have a lot of telangiectasia. As that can happen, it is key to stay ahead of the radiation dermatitis as well.
And similarly, as we discussed with the acute side effects, are there any specific management strategies or prevention strategies that can be used to hopefully mitigate some of these late or long-term effects?
Yes, there are. So I actually happen to have a sexual health clinic for women with these effects. It's very important as nurses that if you can develop the comfort to ask patients about their sexual activity. It's hard, but it really needs to be done. And I will tell you that the healthcare providers are not doing it. They don't have time. And just like nurses, just like us as nurses, we don't get this in school, and neither do they. The other providers don't get it in school either, but it is important. Patients are getting more and more worried about their sexual health. They're coming to us at a younger age. And this is really, really important to address. And things that need to be addressed, it may help you if your patient's being treated with a dilator in place to be able to talk about these issues later on, because patients will expect it. Patients will still need to use a vaginal dilator post-treatment. There are international guidelines that exist that recommend for 1 year. Usually it varies. Usually I use 3 times a week, up to 5 minutes. And if they're sexually active, they can take away 1 time per week. But using a vaginal dilator is really, really important. Secondly, what is important is to use vaginal moisturizers. Early on, if they can tolerate it, some women are motivated and will use them during treatment. I have some patients that will use prescription vaginal estrogen during treatment. But vaginal moisturizing, staying ahead of symptoms. A key point for your younger patients, sadly, your younger women patients, if they have not gone through menopause, radiation will likely put them into menopause unless there was time and they had their ovaries, the oplexy, where they had them picked out of the way of the treatment field. But if not, women will go through menopause sometimes within the next year. They need teaching on that. Nurses need to let them know this is going to happen. Often for these women, when they're young, they're in their 40s, they're often candidates for hormonal replacement therapy, oral hormonal replacement therapy. So it would be important for nursing to remind them they need to get to a gynecologist for a gynecologic exam and discussion about menopause and what they're going to do to handle any symptoms from menopause. Or if it's their primary care provider who does this discussion needs to happen. But I believe that this is going to have to come from nursing. I don't see it coming from the oncologist, at least in my practice. So very, very important part of care for women as they go forward. And it's important to remember it's not just for sex. Women who are in their 30s and 40s who go through menopause have to worry about osteoporosis, which having pelvic radiation within the first 3 years, they can have microfractures, pelvic insufficiency fractures from the radiation. So thinking about osteoporosis, thinking about that they could have cardiovascular effects later on in life. They could be cured from their cancer, but have these other effects. So very, very important, especially with this younger population that we're seeing, for nursing to be involved in a little bit of women's health with these patients.
I think your comments are certainly very timely. I mean, I think in social media, at least, there's definitely a larger, I think, more open conversation about the hormonal impacts that women face in general. And so I think it is very important for oncology nurses to understand how that overlays the patients that we are seeing and perhaps treating for cancer, and how we can, as you did a great job of explaining, of just the risks of perhaps putting somebody into an early menopausal state and then all of the downstream sort of risks and repercussions that can create. So I think it's just a very timely conversation. And as you've said, we know nurses are perfectly positioned to have these conversations that can be sometimes challenging or uncomfortable for patients to openly talk about, but we establish that trust with patients, and those conversations can happen, I think, more naturally if we as nurses are are not afraid to have them. When patients do experience some of the side effects that we've mentioned, whether it's short-term or long-term, how we assess those symptoms, how we document those symptoms can really change how they are acknowledged and how they are treated, especially when we're working along, other interdisciplinary rounds with other providers. And so talk a little bit about what are the standardized tools that you would recommend nurses use when we are evaluating and documenting the symptoms, the side effects that we're seeing.
I would say the most common one, if you want a tool that other providers and other oncology providers and also non-oncology providers understand, it would be the CTCAE, the Common Terminology Criteria for Adverse Events. I mean, they have nausea, they have radiation dermatitis, they have so many different symptoms. If it's something that you become familiar with when you see them documented, for people who are on the EPIC system for documentation, these are in EPIC. This would be an important tool. Tools that have patient-reported outcomes also would be, there's a CTCAE, I think that is a pro, that has patient-reported outcome documentation on it as well, are also important. But those, I would say the tools that not only nursing understands, but other providers understand would be very, very helpful in managing patients.
And then finally, as we come to the close of our episode, just a final opportunity to discuss. You've already mentioned very well about the importance of nurses addressing sexual health for patients who are receiving radiation therapy for any cancer indication, but in our discussion today, of course, specifically for those receiving radiation for their colorectal cancer. How can nurses maybe work along with other healthcare professionals to best address the potential sexual health and sexual side effects that could come from this type of therapy?
I would say that working with your advanced practice providers and education toward advanced practice providers has definitely been focusing on this more. So your PAs and your NPs, I think they're going to have the ears and the wherewithal to be able to be your allies and colleagues in this. By and large, it's my APP colleagues and nursing that I talk to the most about this. So I would say definitely bring it forward. Bring it forward to key people, your nursing leadership in your department, especially, again, it's not an easy thing to bring forward having dilators in place. But I will tell you, in the department that I work in, it was me and a couple of nurses who pushed this issue with the physicians for 2 years and finally got it put in place. It can be done. There's a lot more centers out there doing that. So definitely with your colleagues for sure, especially your advanced practice provider colleagues.
Well, Lorraine, thank you so much for joining me today on the podcast and talking about, I think, this very important topic about side effects that we associate with radiation therapy when it's given for colorectal cancer. I really appreciate your time today and the expertise that you've shared. As we get to the end of the episode, we'd like to run through just a series of some quick questions to summarize some of the great topics that we've covered today. So to start that off, how do you think healthcare professionals should evaluate their hidden or the implicit bias they might hold about just radiation therapy for colorectal cancer in general?
That it is very well tolerated. Patients come to us thinking that they're like going to be so tired they can hardly get out of bed. That's just not the case. Side effects are manageable. They're usually often very minimal on the acute side. They're really well tolerated. Being proactive in care always helps. If somebody is overweight or underweight, don't assume they have the wrong diet. Really explore dietary options. There have been studies done. I actually go by a 2018 randomized controlled study that was done in the UK. There's no set diet for this. There used to be that patients receiving pelvic radiation were told they should be on a low fiber diet. That did not pan out in this randomized controlled trial. In fact, it was the high fiber diet that panned out to be statistically significant. However, the low fiber diet was underpowered, and they believe that that would have been statistically significant. So I would say don't be in a hurry to have your patients change their diets if their weight is okay and they're not otherwise doing anything that's detrimental to their health. Another thing would be don't make any assumptions about sexual health. I know we talked a little bit about young people, but just because somebody's older doesn't mean they're not sexually active. So when you ask your sexual health questions, I would say ask them of everybody. The average age, I would say that I see in my sexual health clinic, 50s and 60s. Definitely don't pin an age on if they're sexually active or not sexually active.
What are some common misconceptions about radiation therapy for colorectal cancer?
Some of the common misconceptions are that it's going to be very painful, that it's going to cause a lot of diarrhea so that patients can never leave the bathroom. They're going a dozen times a day, that it's going to take sex away from them forever, is what I hear a lot as well.
And what's something about this topic that's not often discussed, but you wish people knew more about?
Basically, more and more about the sexual health topics that in the sexual health issues that go along with this would be key. I will say that microinsufficiency fractures, and I talked a little bit about that, can result. Usually they result within the 6 months after radiation. And what they are is a patient will present with pain, mostly it's in the sacral area, but they can just about pinpoint it. You have to ordering an MRI, which is often ordered. The radiologist needs to know that's what they're looking for because these are often pinpoint, these fractures. They commonly, at least I've seen them far more in women than men, women who have a history of osteopenia or osteoporosis, women who are over 40 with a small build will often see them build. Although I've seen them happen in men, especially for patients who've been on prolonged steroid therapy. That is something that can happen. PT often helps. They are often self-limiting, but it is something that to be aware of. And a lot of times patients are not aware of it.
What additional training or education do oncology nurses need to stay current on this topic?
Well, I definitely would say it isn't certification. So they address radiation. So there's that. There's certification. But there's a radiation therapy course, I believe, which is something good to take as well. And just to look for CEU offerings. I know ONS has a radiation therapy track. Just staying on top of all that.
And then finally, are there any resources that you would recommend for patients or either other healthcare professionals who want to learn more?
Yeah, so there's a great online forum called Colon Town that addresses both colon cancer and colorectal patients as well. And then the Colorectal Cancer Alliance is for both providers and patients. Those are specific to colon cancer. I always recommend things like the ASCO guidelines, the American Society of Clinical Oncology, as well as ASTRO, American Society of Therapeutic Radiation Oncology. And of course, ONS for providers. There's also APSHO for advanced practice providers, and for RNs as well. Those are all resources, I believe, that are really helpful.
Well, Lorraine, thank you again for joining us today and for such a great discussion and sharing all of your expertise with our listeners. Do you have any final comments to share?
No, thank you very much for this opportunity because it's such an important subject. We're seeing so much more colorectal cancer in younger people now. So I appreciate the opportunity. Thanks very much.
Thank you. Thank you for listening to the ONS Podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org and ons.org/voice. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.